Hi, I'm Glenn Goloszewski, the Medical Director at Mountain Valley Hospice and Palliative Care. In today's video, we're going to discuss the different levels of care available in our inpatient facilities. The Medicare hospice benefit allows for 3 different types of level of care for a hospice inpatient facility and has set forth guidelines for each of them. Medicare does not intend for any of these levels of care to be long-term solutions. So if inpatient care is needed for weeks or months as opposed to days, your social worker will be happy to assist you in finding long-term placement options. General inpatient of care, or GIP as you'll hear the staff refer to it, is going to be our most common level of care. And it is short-term inpatient care for situations that require an intensity of care that could not feasibly be provided in other settings. For example, a pain crisis or respiratory crisis, or symptoms that are worsening or just not improving with the treatment plan at home. Short-term in Medicare's mind means less than a week, and Medicare requires us to reevaluate the level of care every day, and in particular to justify the medical necessity for general inpatient level of care every single day for every patient. The goal of symptom control is to see symptoms improve to the point where the patient can return home, where we will continue to make medication adjustments if necessary to provide further improved symptom control. The hospice Medicare benefit is set up to focus on enabling patients to be cared for at home because that's what we as Americans asked for when they were creating the medical benefit back in the 1980s. Sometimes as a family member, it's difficult to understand why your loved one may be weaker or interacting less, eating less, having more difficulty swallowing or staying awake, falling, obviously declining. But these issues, as difficult as they are to witness in your loved one, may not be enough to justify the need to be transferred to or remain in an inpatient facility, at least in a general inpatient level of care. So what happens when a person no longer qualifies for the general inpatient level of care? Well, most people return back home again or their previous living facility. If this is not an option, our social worker can assist you in investigating other options, and these may include seeing if we can increase hospice or family support in the home, or a transfer to a skilled nursing facility or an adult living facility, or a change in level of care to residential for a week or two while a longer-term plan is being worked out. The idea of having to move a loved one when they may have only a matter of days to live can seem unnecessary, but unless a patient meets the eligibility requirements for general inpatient, Medicare does not allow a person to remain in general inpatient level of care simply because they are dying. So in the IPU, this creates some uncomfortable conversations where, while the patient may remain in our IPU, we are forced to change the level of care to residential and bill for room and board in order to meet Medicare's regulations. We very much wish that we did not need to do this, especially at such a sensitive time. A similar situation that families sometimes struggle with to understand is why patients with only a few days or maybe a week or two to live are not allowed to just move into the IPU for truly end-of-life care. And we understand where these requests come from. Folks may feel that their home or their bedroom will never be the same if their loved ones die there. There may be young children in the home that you wish to protect from witnessing a parent or a grandparent die. For patients at home in situations where a loved one appears to be dying and the goal is for the person not to die at home, but we're not able to meet Medicare's eligibility for GIP level of care, we may be able to have your loved one transferred to the IPU under a respite stay or a residential stay. Medicare does permit changes back and forth between general inpatient and residential level of care as the patient's condition changes. So if a patient is changed from GIP to residential level of care and their symptoms increase to the point where the patient again meets the criteria of requiring an intensity of care that cannot feasibly be provided in the current setting, a change back to GIP may be medically necessary. Medicare does not permit, however, except in rare situations, a change from GIP to respite level of care. And Medicare's thinking here is during that GIP stay, the caregivers should have taken the opportunity to give themselves a break. Let's talk about residential level of care, or second level of care. This is basically home hospice being temporarily provided in an inpatient facility. So physician and nurse practitioners, just like at home, would only see the patient if there's a medical need to make a visit. They would not automatically see that patient every day. The hospice Medicare benefit is a comprehensive medical benefit, but one thing it does not cover is room and board expenses, and these must, by Medicare regulations, be billed to the patient. Residential level of care must be approved by the IPU manager and paid for a week at a time in advance. If your loved one ends up not staying for the whole time, the unused days will be reimbursed. Like any other inpatient level of care, residential is not intended by Medicare to be a long-term solution. So residential level of care is generally not approved for more than 2 to 4 weeks, and this is a time that represents an opportunity for families to evaluate and select a long-term living situation. Our social work staff is happy to assist you in locating options where beds are currently available. Our third and final level of care in the inpatient facility is called respite. And this is an inpatient stay up to 5 days in duration that is to relieve family members or the person who normally cares for the patient from their caregiving responsibilities for a needed break or to attend a graduation or a wedding, things like that. Respite care cannot be provided in the home, ALF, or residential care facility. So the person goes from their facility to an inpatient facility to receive respite care. It's not brought to them in their house. A patient that's already living in the facility do not have a respite benefit because there's no caregiver exhaustion potential. In a nursing home, they have paid caregivers. Therefore, if one paid caregiver can't show up, the facility is required to replace that caregiver with another one, so there can't be caregiver breakdown. When respite requests are made, the staff is going to inquire into the reason for the request so we can best support you going forward. We want to know answers to questions like, is more hospice support or family involvement needed in order for the patient to be continued to be safely cared for at home? We wanted to see if caregiver exhaustion is actually due to a clinical or functional decline in the patient that results from poorly controlled symptoms, such that maybe a general inpatient stay is more appropriate intervention. We also want to figure out, after 5 days of respite, is going home going to be a feasible plan, or do we need to start discussing other long-term options? While we make every effort to accommodate requests for respite stays, we can't make any guarantees or plan respite stays in advance. And this is because by Medicare regulation, respite stays must be done in a bed that is approved for general inpatient care. So every respite patient means that a GIP is unavailable for GIP use for the next 5 days. Because general inpatient needs may be quite medically urgent, we have to assure that we always have GIP beds available. So this means that you may see an empty room in the IPU and be told that we have no beds. Not all the beds in the IPU are licensed for GIP use, and when we only have one GIP bed available, we cannot offer it for a respite stay at that time. So there may in fact be empty beds, but they may not be the kind of bed that your loved one needs at that time. So how do we accommodate respite needs? Well, the IPU census, like any hospital census, is going to fluctuate daily with patients coming and going from our facility. So each of our 2 IPUs maintains a triage list of all respite requests, and we accommodate requests based on the urgency of the need. Because we're unable to guarantee a respite stay precisely when needed, it's necessary for families to develop a backup plan, and ideally, the plan should be in place before we have a need for respite care. The Medicare hospice benefit was created to allow patients to remain at home for end-of-life care. It's not Medicare's intention for respite stays to become a long-term or a frequent solution. So if we're feeling the need for frequent caregiver breaks, our staff will assist you in trying to find more in-home help or looking into other long-term options. We hope that you found this video informative and helpful. Please let your hospice care team know if you have any questions or need more information.